All right. Thank you, Jeff. Good evening, everyone, and welcome to this HepaTalk webinar. My name is Dr. Jeffrey Yu, co-founder of NextGen Therapeutics. On behalf of my co-founders, Dr. Ray Dong, Wayne Chen, and Lily Guan, I want to thank you all for being here with us tonight. In my own practice as a gastroenterologist, I see patients with MASLD every day. This condition is no longer confined to academic discussions. It is part of routine clinical care. That's why I'm especially passionate about non-invasive tools like transient elastography. And not to promote any one device, but because they represent an important educational and clinical advancement, we should bring to the broader medical community, including primary care and endocrinology. It's now my pleasure to introduce Dr. Deepika Devuni, a transplant hepatologist and associate professor of medicine at UMass Chan Medical School. She will share updates on nomenclature changes, prevalence, systemic impact, and the importance of early screening and non-invasive testing. Dr. Devuni, the floor is yours.
Thank you, Jeff. So I'll share. Thank you everyone for joining. I know for some people in the East Coast, it's late in the evening. Can you guys hear me? Right. So I'm going to talk about like trends in MASH and MASLD and how we can screen and what are the guidelines. So I think I always usually start this with change in nomenclature. I think like across the board, like there's a move for moving away from stigmatizing ways we use the disease. Especially like, for example, with patients with alcohol, we keep saying alcoholic liver disease, alcoholic patients. So there's like a lot of stigma associated with this. This leads to patients not coming to care or like actually like hiding their disease. So there was a whole Delphi consensus conference with ASLD, EASL, and South Asia, Latin American conferences to rename the steatotic liver disease under a big umbrella. So the way we talk about steatotic liver disease is alcohol-associated liver disease or alcohol-related liver disease. And then there are diseases which are specific steatotic liver disease, which are drug-induced or like monogenic diseases like Wilson disease and things like that. And there's cryptogenic steatotic liver disease. What we're going to focus mostly is this first category of MASLD and MASH. What used to be like NAFLD or non-alcoholic fatty liver disease is now called as metabolic dysfunction associated steatotic liver disease. I know it's a mouthful to say. What we say in the GI is MASLD. And those MASLD patients with inflammation, which is to be NASH, is now MASH. I think in a way it makes sense because non-alcoholic fatty liver disease just is like, oh, the patient's not drinking, they're obese, and that's like the only reason, which actually like makes it minimizes the whole extent of patient's pathophysiology. There's a whole different nomenclature here called MET-ALD, which is like combination of patients who have MASLD or obesity and metabolic risk factors and are also drinking alcohol. So the way we differentiate as MASLD predominant and alcohol predominant is based on how much alcohol they're drinking. Obviously, if the patient, like the way we do it is like 20 to 50 grams in female and 30 to 60 grams in male, that comes to 1 to 2 drinks in women and then 3 to 4 drinks in men is how we think about these things. So this is something I think we should all kind of start using in our everyday life instead of saying non-alcoholic fatty liver disease and alcoholic fatty liver disease, just MASLD, MASH for this talk. So what are the various, so this is why we talk about as MASLD as metabolic dysfunction, because there's various cardiometabolic risk factors which are associated with patients with MASLD. So BMI of greater than 25, which is actually overweight. Remember, if you have South Asian population in your practice or you're from a different country, so the BMI cutoffs for South Asians is 23. It's very important because if you're seeing these patients and if they're over 23 BMI and you're not advising them about weight loss, you're doing them a disservice. And then fasting serum glucose of over 100 or like hemoglobin A1C over 5.7 or patient already diagnosed with type 2 diabetes, high blood pressure or or already on antihypertensive drug therapy by the time they come to see you, plasma triglycerides over 150 or already on statins, and same thing for HDL less than 40 or if they're already on a statin. There's guidelines for pediatrics because if you think MASLD is prevalent in adults, it's also significantly and highly prevalent now in kids. And it's important if you're a pediatric patient or you're somebody who takes care of both, it's important to know the criteria in pediatrics as well. So this is a brief history of MASLD. We've known about this disease for like a whole 2 centuries. The first time it was described was in 1836, and it took almost like almost like 150 years to actually like histologically look at it. Ludwig actually looked at the histology and they said, oh, it looks like alcohol-associated steatohepatitis. Similar kind of picture. That's how we diagnosed it. And as time went on, people realized that there is like insulin resistance in these patients, and there's also like lean NAFL was diagnosed around in 2000s. And as we just talked about in 2023 is when the nomenclature and guidelines have changed. So this is a disease which is not new, but like lot of new changes in the last 5 years. So what is the prevalence of NAFLD? With the cure in hepatitis C, what we are seeing is two diseases which have come up significantly, which is NAFLD, which is now MASLD, and alcohol-associated liver disease. But coming to MASLD, the highest prevalence is in Latin America, and then also MENA, which is a region like Middle East and North America. So the highest prevalence is actually like increasing dramatically in these countries, and South Asia, because remember their BMI cutoffs are lower, and also they have significant cardiometabolic risk factors. In North America, your population is around like 31 to 33%. So again, but once we have to remember as we are practicing, it's important to know who your patient population is. Like, so my practice in Massachusetts, we have significant amount of South Asians and also a lot of Latin American patients. So it's important for me to understand that, hey, my patient could have significantly higher risk of MASL prevalence than an average patient in my clinic. So this is an interesting study which was published in JAMA, which actually like looked at the modeling as to what is going to happen with both MASLD and MASH over the next 30 years. What they have shown from 2020 to 2050, that there is going to be a significant increase, like the MASL cases are going to go up from 5.8 to 7.9% in US. And as compared to MASH, which is described as with fibrosis, the increase is going to be from 6.7 million to 11.7 million patients. So interestingly, you can say, hey, there's new drugs come up, which I'll talk about, but is it making an impact? And they actually, resmetirom, which was already published by the time this paper came out, they actually controlled for it. And they still see that there is significant increase in MASL. So we all have to be very vigilant about how we screen and treat these patients. So the thing to remember with MASH, which is the inflammatory part of MASL, this is a systemic complications. So it not only impacts the liver, but impacts every part of the body. So patients can have atherosclerotic disease, or can have strokes, coronary artery disease, hypertension. In liver, it can cause fibrosis, cirrhosis, and hepatocellular carcinoma. And then once you develop cirrhosis, you can have liver-related clinical outcomes. And in patients with kidney, you can have kidney disease. And remember all of the metabolic dysfunctions like prediabetes, dyslipidemia, hypertriglyceridemia, and systemic inflammation. And then also osteoporosis and hypothyroidism. One of the things I think we forget very commonly is because we are seeing the patients are obese and they're not frail. We don't think of sarcopenia in patients with MASH and MASL, but more data is coming out that like actually MASH impacts even like skeletal muscle and then can lead to sarcopenia in this patient, so which is an important thing to keep in mind. So this is an interesting way to look at this slide, because the reason this is important is like patients with diabetes who are actually being followed chronically in both PCP offices and endocrinologists are actually ideal candidates for in whom we can screen. So this is like from the Paris MASH meeting. Every year, a group of MASH specialists meet in Paris, and they come up with like newer ideas, and they like a round table kind of thing. So what they show that like MASL with type 2 diabetes has like less, without type 2 diabetes has less fibrosis, as compared to like MASL with type 2 diabetes, which is in red. As you can see, more patients who have MASL and type 2 diabetes have actually fibrosis and cirrhosis. And if you don't intervene, that's what is going to happen. So in brief, I think Dr. Wu is going to go over more detailedly about like screening, but I'll also talk about non-invasive testing. So the first step to do is like easiest way to do is blood work, which is a FIB-4 score. So FIB-4 score is actually only based on 4 values. So this is everybody. PCPs usually test it, endocrinologists test it, gastroenterologists. We are all doing these labs, right? We are doing AST, ALT, CPC, and an age. And then it gives you a number between like low risk, which is less than 1.3, intermediate is 1.3 to 2.67, and high risk is over 2.67. So then you calculate it and it gives you a number. So then what do we do? And like if the patient, and that's how we kind of start with the screening process. And this, everybody can do it. And if you have Epic, for you, I'm like North American users, if you have Epic healthcare system, if you just do .fib4, Epic actually gives you the fib4 value. So some health systems have actually incorporated it into their, like just like labs, like, you know, how CPC, CMP, and it's fib4 built into the system that you can do. So what are the non-invasive imaging tests we can do is vibration controlled transient elastography. There's used to be only FibroScan, but now we have iLive Touch, which I think we'll talk about more, and then MR elastography. So FibroScan, which is made by EchoSense, this is what we are all most commonly used to because this is what we had. We use this mostly in moderate to high risk FIB4 patients, so those who are over 1.3. And then the way FibroScans or any vibration controlled transient elastography works is it measures a sound wave passes through the liver, and based on how fast the sound wave kind of goes through the liver, it gives you a number and it tells us how stiff the liver is. That's what we're calculating is liver stiffness, which we also equated with fibrosis. So KPA is what the kilopascal is, what the fibrosis scoring is. And if it's less than 8, it actually like excludes significant fibrosis. It also gives you a number for steatosis. It gives you like stage 1, stage 2, stage 3 of steatosis. It's a good way to know, but I think the low steatosis and very high steatosis is great. The in between is like a gray area. The problem with steatosis grading is if there's inflammation, alcohol use, or if patients have just eaten their food, that number may sometimes be high. So the main problem, if you have used FibroScan in your system, what you'll know is like it's very user dependent. And once you start putting in this, like the shear wave, you'll see that either it's very high or it's very low. The liver, you cannot like literally like locate it well. That is actually like kind of iLive Touch, which is made by High Sky Medical, helps with the ultrasound guided imaging. So you literally can see where the liver is as you pass your sound wave through it. And then it gives you a number, and then they give you cutoffs as to what the risk is. So MR elastography, it is proton density fractioning. It's actually considered most accurate, used in like clinical trials, but it's not widely available, and it's also not well covered by insurances. I don't know how easy it is for you guys, but we have to like every time there's a MR elastography, we have to call the insurance, do a prior auth and stuff like that. And also it's not something you can routinely follow because it's expensive and patients don't want to do MRI because they don't like the machine itself. So what are all the screening guidelines, right? What are various societies saying about MASLD now that the prevalence is so much higher? So a lot. Everybody's luckily saying the same thing, so it's not like very different from each other. So first thing we'll start about is ASLD, which is American Association of Society of Liver Diseases. They came up with these guidelines. So as you can see, like MASLD is so prevalent that all the care of this cannot come to hepatologists or gastroenterologists because it's just impossible for gastroenterologists and hepatologists to see all of these patients. And then it would be a disservice for the patients to be not taken care of. So usually like we think about starting it at primary care or endocrinology or non-GI hepatology care. You start off with like risk factors and you do a primary risk assessment and you calculate a FIB4 score. If it's less than 1.3, you follow them in your clinic, you modify the risk factors. If it's over 2.67, you send it to hepatology. And then if it's in between, one of the ways you can decide if they're high or low is to do a vibration controlled transient elastography. And then kind of if it's higher KPA, then you send them to hepatology. What do hepatologists or gastroenterologists do when the patient's sent to us? We might make sure there's no other underlying liver disease. Very rare cases we consider doing biopsies, but most of the time we do if the transient elastography has not been performed, we use that to guide our further treatment. Obviously, if patient has cirrhosis, they go down the pathway of cirrhosis management, but we focus mostly on stage 1, 2 to 3 is where all the most important like meat is now because we have pharmacotherapy available. Similarly, this is APASL guidelines, which is Asia Pacific Association of Society of Liver Diseases. They're very similar to ASLD, but they actually have a category called lean NASH because there are a lot of patients in South Asia where patients are lean and their BMI is less than 30, but they have significant cardiometabolic risk factors. So remember, if this patient is seen in your practice in North America, they will have same kind of physiology. So they could be lean and you may never think that they have NASH going on, but if you like image them or if you do a transient elastography or calculate a FIB4, you will see that they may be at higher risk of these patients. So it's a similar thing. You calculate the FIB4, then you do the transient elastography, and then you base on where what you want to do with that information. EASL guidelines actually are very clear, very similar. They describe the same thing. If it's over 2.67 or greater than 8 kilopascal on transient elastography, you send them to hepatology. Otherwise, you do the intensified management of comorbidities. That means like diabetes management, cholesterol, nutrition, and all of that stuff. So the good thing is like now American Diabetes Association has also understood that like, this is something they can do. This is something you can actually partner with if you are a gastroenterologist, you can partner with your PCPs and endocrinologists in your office or in your institution. This is what we have done. We have gotten an internal grant and every diabetes patient who goes into like diabetes clinic now gets a FIB4 score. And we've created a pathway for our diabetes providers so that they clearly understand which patients need to be sent to us and what are the next steps to do, how they can directly do a transient elastography without actually waiting for people to just send the patient and wait for years to be seen by a hepatologist. This is from American College of Endocrinologists, very similar. They do say like, increased risk of cirrhosis in patients is when they're greater than 50. They have type 2 diabetes. You have to be more vigilant and do active things. Very similar guidelines from International Diabetes Federation. Everyone has bought into FIB4 followed by transient elastography. Very few people actually recommend biopsies. So what is the excitement? Like that's all screening. We have new non-invasive ways to screen. But then comes like, if you have been a practicing gastroenterologist for a few years, like I've done this for more than 10 years, I've had patients who've had MASLD and they've progressed to cirrhosis in front of my eyes in the last 5 years and then needing a transplant. And it's very frustrating to see this. But now FDA has come up with these two guidelines for what is the endpoints for treatment. One is MASH resolution without worsening of fibrosis, and then improvement of fibrosis of more than one stage without worsening of MASH. So there are a plethora of drugs coming up in a market, but most of the times they don't meet the endpoints and some of them go off the market. But there are a lot coming up in the next few years. But the exciting part is we do have 2 approved FDA agents. One of them is resmetirom, which is made by Madrigal, which I'll talk about in the next slide. This has been in the market for a year and a half now. And as of like hot news, semaglutide, which got approved like last month, which is like a GLP-1 agonist we use for diabetes. We used to use for diabetes with MASH or diabetes with weight loss, but now it's approved for independently for MASH with or without diabetes. The advantage of that is like now other people can treat it, like, gastroenterologists can give it because it has an FDA approval for MASH as compared to like before, if it was not, I would use it. Like, I would ask my endocrinologist to use it for me, but then I did not have that approval of like FDA to say, hey, you should do this medication. You can do them in combination or you can do them separately. So resmetirom, the way it got approved is MASTRO-NASH study, which is published in New England Journal of Medicine. So they used like 80 milligrams and 100 milligrams based on the weight and compared it to placebo. And they showed the first endpoint, right? Like MASH resolution without worsening of fibrosis in 25.9% and 30% as compared to 9.7%. And fibrosis score improvement with no worsening of NAS, which is NASH Activity Index score. And then up to like quarter of patients actually had improvement as compared to placebo. So this is what led to its approval. It took us it's a year and a half. We've had multiple patients on it, and we usually wait a whole year before we check to see if their fibrosis or if their steatosis has improved, because it takes some time to changes to happen. One thing has to remember is resmetirom is a weight neutral drug, so patients' weight will not be changing on it. So if patients are expecting that weight loss is something they'll think, they may not be very happy. But most common side effects are like nausea, vomiting, and like diarrhea and stuff. So patients actually tolerate it very well, and most patients do not have much of side effects with this medication. The semaglutide, the Essence trial, which was also recently published, this is actually a phase 3 randomized double-blind control trial. They had 800 patients. They put it in like 2:1 ratio, so two of the ratio will get the drug and 1% will get the placebo. This study was actually like for 240 weeks. And at the end of 72 weeks, they did like a interim analysis, and they found clinically significant changes. like up to 62.9% of patients on semaglutide at 2.4 milligrams actually had a resolution of NASH. So this led to like an accelerated FDA approval. And so now you have it. So the way we pre-assess this, and what we've done is we've created a MASH champion hepatologist, and either you can choose directly to prescribe the medication yourself or you send it to the MASH champion, and then they, along with the APP groups or advanced therapeutic groups, like start the patient at a lower dose and kind of go up and see how much they can tolerate, because you can't start at 2.4 semaglutide. Patient's going to have a lot of side effects. So you start at a lower dose and you kind of slowly build up over a 2 month or 3-4 month period, and then you see how they do. Hopefully we'll have a lot more drug approvals, because one of the main issues we were having was like the availability, or like insurance companies having issues with it. But now that approval is here, you may be able to use it more significantly. So this is exciting times, like in MASH, because finally we can offer something to our patients. So my take-home points are like MASH, or actually any disease, I think, is multidisciplinary. And it says it starts with a hepatologist, but I feel it starts with primary care or an endocrinologist, because you are the first contact person for the patient, and you screen and then you kind of assess them. There's still role for obesity and bariatric medicine in patients who are significantly like BMIs over 50. Sometimes you may just have to consider doing bariatric surgery and then start them on medications. Nutrition and lifestyle support is very important. And because of the sarcopenia, it's important to consider physiologists and then improve the sarcopenia aspect of it. One of the things I think gets underspoken in patients with MASH is behavioral health. We are all focused on behavioral health in patients with alcohol because we're so obsessed about it. But I feel like it's the same thing. Patients have binge eating disorders or underlying anxiety and depression, and use food as a source of comfort. So it also helps to have the change of pattern in how people eat. And then also it's important to have cardiometabolic risk management. So it's important to have preventive cardiology as part of your team. So that can help with it. And use non-invasive tests, screen your patients, and then there is liver-directed therapy, so please use them. I mean, at this point, I think we have PCPs who are using semaglutide in our clinics. Resmetirom is something is still like GI is doing it. Thank you.
All right. Thank you, Dr. Devuni. I'm sorry, I think my frame is frozen. But thank you, Dr. Devuni, for that excellent overview and for highlighting the evolving management landscape. And to build on that, I'd like to welcome Dr. Stephen Wu, a gastroenterologist and hepatologist from California with more than 20 years of clinical experience. He will be sharing how transient elastography is helping him manage patients with MASLD, collaborate with primary care and endocrinology, and improve early intervention. Dr. Wu, please go ahead.
Thank you very much for the introduction, and thank you for the previous Dr. Devuni, wonderful talk. So let's talk about, it's very excited. Sorry. Okay, so let's talk a little bit about the disease. As we know, it's coming more frequently in the United States. Almost 100 million patients going to go into the MASLD or MASH. And we just heard the presentation. This will affect a lot of our patients. And previously, we know alcohol liver disease or virus hepatitis has a contribution to the liver cirrhosis and the liver transplant. And now we know this is going to be the major problem for the MASH. And the MASH has a lot of problem coming from the obesity, type 2 diabetes, and the metabolic syndrome. And we know the normal liver and go into the liver fibrosis. So that's the most important. We don't want to wait until liver cirrhosis because it might be a little bit too late, and then go into the problems, liver failure and liver cancer. That's a consequence of the liver fibrosis. So as we know, liver disease, this is the common pathway. So how can we prevent that? That's very important. We wanted to find out earlier and use the different method, and then prevent it to go into liver cirrhosis. Previously, we think liver cirrhosis is point of no return, and we wanted to do the fibrosis in the F1 F2, F3 to be detected and treated accordingly. But right now, more and more evidence shows even in the liver cirrhosis still can be reversible, especially in the hepatitis B and C era already proved that. And hopefully for the MASH, we do not have enough data yet because we don't have the treatment. As we mentioned, Restifra has lately approved for the F4 disease, and the data still not enough for us to talk. So as we understand, in the healthy liver, which the fat only less than 5% of the hepatocyte. Now, with the obesity and the high cholesterol, high triglyceride, and the genetic issue, as well as type 2 diabetes and the insulin resistance can go into the muscle and then leading into the MASH. As we mentioned, the muscle is that the fat is more than 5% of the liver cell hepatocyte, and with the ballooning of the hepatocyte and then leading into the muscle, and then go into the next problems. Once you go into the inflammation, ballooning, and fibrosis, that's the problem. We wanted to catch early in the MASH, preferably in the F2, F3, not into F4, and then prevent the liver cirrhosis. So that's the latest stage of fibrosis, hence into the hepatoma, and which has much more consequence with the liver transplant. And as we know, there's a shortage of the organ at this point. And we have to understand more than half of the patient with obesity or type 2 diabetes that has muscle, and it's very important. So we can coordinate with a primary care doctor and the endocrine specialist to screen and find out in the early stage. And previously, we already know liver biopsy is the best one. It's more accurate. However, the problem with the liver biopsy is, first of all, it's invasive, even though under the ultrasound guide, it's much easier. I remember in good old days, we just used the percussion technique to do the blind liver biopsy. The only things we worry about is that after the liver biopsy, the patient call in, say they have abdominal pain, and which would be worry about the rupture. But now with the ultrasound guide, it's much safer. However, the limitation is that we need to know, we need to have a cold biopsy, and the sampling error is the problem. And number two, interpretation of the liver biopsy also a problem. Number three is very, very expensive. So, and in the clinically, very few patients is waiting to go for the liver biopsy. Of course, in the tertiary care, it's much easier. Number two is a serology test. It's minimally invasive. However, it's not very accurate, and still very expensive, and pending on the insurance approval. So that's the problem on those two. So now we go into the more important is imaging method, as previously we mentioned, ultrasound and MR elastography. And ultrasound is not that accurate in terms of the fibrosis evaluation, and it is not quantitative. So the accuracy for the fibrosis is much less. So that's the problem. And the MR elastography is very good. However, it's too expensive, and the insurance company will not approve, even though we try very hard to fight for that. And if we have an easier technique to dictate, we don't need to spend so much time. And also it has to be in the facility to have the MR, and also interpretation is also the other problem. So now let's talk about the transient elastography. And previously, Dr. Devuni speak very well. The vibration control, the transient elastography, stand for VCTE, use the 50 Hertz pressure-induced shear wave with a 3 centimeter of liver parenchyma. This is a FDA approved biomarker for the liver fibrosis. And you can see the left diagram and the right diagram. You have to intercostal to avoid the rib and to look in to do the imaging. The liver stiffness, two part. One is stiffness, is for the so-called fibrosis, and the second part is for the steatosis. Those are the two components for this transient elastography. Now, let's talk a little bit on that. What is the target portion, and then move into the liver disease and how can we do it? So in the general population, healthy people, how can we do the screening? As we mentioned about previously, there's a few metabolic disease, high cholesterol, obesity, and diabetes. Those all the risk for that. And as we all know, liver disease is a silent killer. There's no symptom most of the time. Only when they get into the very, very late stage and started to have the symptom, but at that time probably too late. So we want to do it at the early stage. That's most important. So we are focused on the liver fibrosis, especially in F2 or F3, and that we can prevent all those complications. Once you have the liver cirrhosis, we need to treat more aggressively, and then possible liver transplant and hepatoma is one of the major reasons to lead into this complication. As we know nowadays, the transient elastography is more popular, which is being adopted by the different society, as we all know. So now let's talk a little bit about the diagnostic approach to prevent the liver cirrhosis who has the MASLD. As we mentioned that previously, the patient with type 2 diabetes or pre-diabetes or obesity with one cardiovascular risk, it can go into that. How do we screen in FIFO? And FIFO, we already previously as a good presentation. It's easy to calculate. Once it's low risk, then we can have the primary care doctor to monitor and every 1 to 2 years. However, if the FIFO is greater than 1.3 at this time, it's high risk for the advanced liver disease. So we need to look into the liver stiffness. If it's greater than 8 kPa, and then we need to evaluate. If it's less than 8, then they can go back to the primary care doctor. If greater than that, that's the time for us, a liver specialist, to do the further evaluation and treatment plan. Okay, so now for those primary care or non-GI or liver disease, they can use the FIFO and then refer to us for the further evaluation. And as we mentioned, that elastography is one of very important part. However, if the FIFO index is too high, you don't need to wait. Direct refer to us for the further evaluation. And this diagram previously already shared with our previous doctor regarding this part. I'm not going to go too deep. This is just a stepwise. So most important is the liver steatosis and liver fibrosis. That's a key point for us to look into the liver disease. So now, the clinical indication for the transient elastography. Number one is diabetes. We all know that. Previously, talking about the patient with diabetes versus non-diabetes with MASH, they have much higher risk of complication that we all know of. And not only in the MASH, especially in the other liver disease, which shows the same result. Obesity and the metabolic syndrome also has a very important relation to the MASH. And we need to know abnormal liver enzyme without any clear etiology, which include, as we know, viral hepatitis, which include hepatitis B, hepatitis C, and also include the well-sensitive disease, alpha-1 antitrypsin deficiency, PBC, PSC, etc. We need to first of all do the extensive workup. And if this all negative, then we go into the so-called MASH or MASLD. The fatty liver on ultrasound, as we mentioned, the ultrasound cannot do the quantitative fat evaluation, also operative dependent. And nowadays in the US, the only problem ultrasound is operated and by the technician. I know in the Asian country, especially in Taiwan or in Japan, Taiwan, the hepatologists usually doing the ultrasound, so the accuracy is much higher. But in the US, most of the time, we have the technician to do that. Then they took the picture, and depends how good they are, and that the radiologist to read it. And the other things is hypertension, high cholesterol. That's all related to that. Okay, so the right side is talking about all the possible of the ICD-10 for the different liver disease. So now it's very important. This is a teamwork. First of all, and we need to know the health checkup is important. As a hepatology and the endocrine PCP, that's all important part in the loop. However, we need to prevent. How can we prevent? We need to screen. And once we screen, we need to refer to the gastroenterologist or hepatologist, and then do further treatment plan. As I mentioned previously, hepatitis B, C, alcohol liver disease, DD, and the metabolic disease induce the injury, autoimmune PBC, PSC, all those can induce the harm. Okay, thank you. Let me go back. Okay, so let me close in this way. First of all, early detection. Number two, the fibrosis is the key. Once we detected fibrosis, that's the next. What can we do? So now we have all those available FibroScan, and the FibroScan previously has their good and bad part. Right now, we need a more easy way, and his company has come out with a new machine, and hopefully this will be another easy way to do that. That's our expectation. And the Valacure and the problem, they have a more operative problem at this point, that to my knowledge. To most of the hepatologists who use the Valacure has spent much more time compared to the FibroScan, and that's in a clinical setting, especially like in high volume, the hepatology practice. We like to have an easy operative, more accurate. That's the key. So that's what we should do in the future. And the treatment, let me just say a few words. The treatment so far approved for the F2, F3, and now for the F4, and it's so important for us to see the long-term follow-up on that particular part. And the other thing is that how frequently should we use the transient elastography to re-evaluate the patient condition after treatment? There's still no standard recommendation, even though from the AASLD, we still no standard recommendation. And hopefully in the next few years, we have a more idea. We should be able to have more advanced guideline. Lastly, is the lean fatty liver. Lean fatty liver, that's the major problem at this point. Asian population, as we know, the obesity in the non-Asian, we're talking about the BMI greater than 30. For the Asian population, we're talking about the BMI less than 28, but we see the patient even under BMI under 21. In my practice, I see probably has 10% still going to the MASH, not only muscle, MASH. So that's the scary part. And there's no standard recommendation at this point. So that's the future part in that. We know diabetes, high cholesterol, etc., but lean fatty liver is going to be very important next topic, especially for the Asian population, and to be resolved. That's all my presentation. Thank you so much.
All right, thank you, Dr. Wu, for sharing your practical insights and showing how transient elastography is being applied in real-world practice to improve patient care. So tonight we've heard two important perspectives from Dr. Devuni, who gave us the bigger picture, how MASLD is changing in prevalence, how guidelines are evolving, and how early screening matters. And Dr. Wu showed us what that looks like in clinical practice with non-invasive testing, making it easier to identify patients earlier and guide care more effectively. So with that, we'd like to hear more from you, the audience. Let's open things up for a brief Q&A. Please go ahead and drop your questions into the chat, and we'll cover as many as time allows. All right, let's give
Jeff, there's a question in the chat saying from Chris Peters, like if you can use transient elastography in the office setting. And actually, we only use transient elastography in the office setting, so we don't use it like in patients, right? So it's in clinic. You can either use it when I see a patient, either I can do it like within less than 5 minutes, or usually like we have a room for transient elastography with the machine set up, and our nurse does it, and then I get the values, and then I can talk to the patient in the real time when it happens with the results. So it's less than 5 minutes. So when the patient comes into the check-in, you can like get their vitals and then take them to the room and just do the elastography, and then you can discuss the results in your clinic visit.
Yes, I know in some medical offices they actually build that into the clinical visit so that these patients get the scan before the actual office visit. So by the time you go in to see the doctor, you'll have time to go over the results. So it can definitely be very, very useful and make a very efficient office visit.
And then Lily has a question saying that she would love to know more about iLive Touch and what's the maximum BMI that it can measure. So Lily said no, it was just like to see if she can see the questions. Okay, I was wondering.
Well, I know from
I have a question actually. Thank you, Dr. Devuni, Dr. Wu. That was a great presentation. I guess I'll just pick Dr. Wu because I'm curious. Your experience in the Asian communities, and you probably see a lot of lean, Asian with fatty liver. My question is that when you see these chronic fatty liver patients, how often do you bring them back to do a transient elastography and do the routine blood work to see where they are right now? And so I'm just curious, in your own practice, how do you manage them?
That's a wonderful question. So first of all, the lean fatty liver is the challenge. Lucky enough, I'm doing the ultrasound in my office myself. Yeah, I've been doing this when I was in training. I learned from the technician. So once we see the fatty liver from the ultrasound, mild, moderate, or diffuse, that's what they can tell. That's number one. We are, even though the BMI is very low, then we go for the fibroscan. I'm the first, I believe the third one in the California to have fibroscan at that time, and then go from there. So the next question is, how frequently do we bring the patient back? Previously, when we don't have any treatment until last year, the headache is that now what? You diagnose me with the fibrosis, now what? What can we do? But now we do have the treatment, and I'm sure it's coming. So the only GLP-1, the only problems injection is going to be the barrier for the patient. And the oral medication is much easier to try. And so your question is so good, is how frequent should we bring the patient? Now we have a treatment option. And so don't ignore the patient. So usually it depends. If I see the fatty liver from the ultrasound, I bring them all in. If I see them have abnormal liver enzyme without any etiology, we can identify, we bring them into this part and go from there. And once we excluded everything else, we know it's a MASH and it's lean fatty liver. This is really the part. What can we do in the future? And what population can, just like a little bit different, like we see for hepatitis B, all the people comes from Asian, we should check for the viral hepatitis. So in the future, this is a point that we probably need to emphasize more. So that's the question. How frequently? There's no definitive previously without medication. I bring them back every 6 months. And now if they have a fibrosis to the F4, that's a different story. So then there any complication? Do we need to see them more frequently? Those are the things. And are there comorbidity in addition to the lymphatic liver?
Great, thank you.
You're very welcome.
We have another question here. Looking ahead, what do you think the greatest challenge will be for preventing MASLD from becoming the leading cause of liver transplant?
I think it is like becoming the leading cause. I think the main issue is screening and early treatment. I think that's going to be I think that's where we are at as linkage to care at this point. I think we provided you with enough tools today to understand that people need to be screened. If you don't screen, you'll never find it. But once you screen, linkage to care is the key factor. I think the best way is to have champions within each institution, to be their MASH person, or even within primary care, to have metabolic clinics within primary care or metabolic clinics within endocrinology, and have aggressive multidisciplinary modification. So if we do that significantly and I think one of the things we also always have to remember with these patients is talk to them about alcohol abstinence or minimal alcohol use, because we are so focused on their fatty liver that we're not talking about the alcohol. So I think if we do this, I think with introduction of all these new factors, I think there will be a I wouldn't say the trajectory of increase is going to come down. I don't think we are going to be at this point right now that it's not going to be a cause, but at least we can say we are making active changes. I think changes need to happen at a societal and also institutional and government policy level. So it's a multifactorial, but I think from the clinician standpoint of view, what we could do is screen and linkage to care and early treatment.
Yeah,
and
absolutely. Go ahead, Dr.
And as we know, the obesity in the United States, in way back to 1985, it's only 15 states. 1895 is 25 states, and then 2005 is 35, and then 2015 is about 40 something. Right now, it's 50 states. All the obesity is because of the diet and the sugar. So those are the things. And how can we prevent? And the other thing is we don't want to go into the liver cirrhosis. For you guys in academic, you see more advanced disease. For us, the how can we prevent that? That's the key point in the future. And the liver cirrhosis, what's the rate of the liver cirrhosis? We know Hep C has, if you don't treat, it's going to the liver cirrhosis after 10 years. For the Hep B, you don't need the liver cirrhosis, it can go into the hepatoma. So now the question is on the MASH, what percentage will go into the liver cancer without the liver cirrhosis, or those are the unanswered question we need to find out. So that's early prevention is a very important entry.
Yeah, I agree. My practice is in Eastern North Carolina, where obesity rate is very, very high. And I think one of the things that we do to ensure that our patients get appropriate care is we take a very proactive stance in terms of screening these patients. Well, we always educate the patients on the prevalence of fatty liver, and we have something in place in our workflow in which our medical assistants sort of um, look for these risk factors in patients that are coming in for whether for endoscopy or just clinic visits. They'll look for risk factors such as hypertension, hyperlipidemia, high BMI, or diabetes. And then they'll flag them on the chart for me so that whenever I see these patients, I'll have a separate discussion with them about their risk factors and why they needed to be screened for fatty liver. And through that, safeguard in place, I'm actually able to pick up a lot of patients that need it, and not surprisingly, many of those patients have F2, F3 fibrosis, and I've actually put them on treatment with well, mostly Resdifra up until now. I know that Wegovy was just recently approved. So I'm very excited to see how this change in my practice workflow will impact my patients. Currently, we do have them come back every 6 months or so for a rescan just to see how the fibrosis changes within that 6 months period. So it'll be a very interesting ongoing endeavor for sure.
The
Um,
next problem is that the reimbursement. And as we know, the reimbursement is so low at this point, and the insurance company. So how can we encourage the GI and the hepatologists to have the machine and two-part, as previously would be ideal one-step follow-up. However, if you do the fibroscan and the office visit all together, you're going to face the problem. In the academic, it might be easier because of the no, not easy. I thought it's easy because pretty much you need to afford everything, and if they don't pay you, then that's the barrier. So that's one of unresolved. And how can we, as a society in the future, how can we insensitize the patient that the insurance company understand the consequence of the liver cirrhosis, and there's no answer regarding 6 months. If you rescan them, are they going to pay for it or not? If we do the study, probably easy. If you don't do the study, the reimbursement is a problem. Of course, the liver cirrhosis probably they have no choice, right? So then that's in the future, I believe we all face this.
Mm-hmm. Yeah, very, very good point that you bring up. I will say though, in my practice, we have reached a point where we have done 6 months interval scans. I have not encountered a situation where the insurance hasn't paid, but of course that's not to say that every insurance will cover it. But I think especially when we're dealing with new medications that are being approved, which I think more will be approved soon too. That it's important for us to take a proactive stance to see how these medications affect the patients in the real clinical world. I mean, in research, a lot of things are, controlled, but in the real clinical world, I think it is left up to us as physicians to take a proactive stance. So I'm very curious to see, hopefully, insurance companies will continue to reimburse physicians who are taking on this active role in a growing epidemic that we're trying to tackle.
Yeah, I agree with you, Jeff. Like, I mean, we've had like people who we've done like every 6 months to a year kind of thing, and we've not had any issues. Our issues are most like if you do it on the same day as their visit, sometimes that's when it doesn't get covered as much. But then if you bring them back like within 6 months, but
Mhm.
sometimes if the patient's coming from 2 hours away, like to come back for a fiber scan for 5 minutes, you just like have to suck it up and just like,
Yeah,
whatever, like do it. But
right.
yeah,
I
but I think
agree.
every 6 months follow-up has not been an issue actually.
Hmm. And Dr. Wu, I think to answer your question regarding reimbursement, I know that currently there are two CPT codes that are reimbursable. One is 91200. which is a scan that you do without the bead mode imaging feature to sort of locate the liver. I understand that HiSky recently had their BMO imaging feature FDA cleared. So in their newer devices, they do carry that capability, which would allow a higher CPT code of billing for 76981. So hopefully that'll incentivize physicians to take a more proactive role.
But however, there's two problem. Number one is the B mode. So if you scan on that, you have to mention on that you do not see entire liver, you might miss something. So that's the problem. If you charge for that one, so those are very important. If you B mode, because you can charge the higher level of those two code. However, that's concerned how accuracy when you do that because you already into the ultrasound mode. And the ultrasound mode, we're looking for the tumor, etc. Not only the fibrosis part. So that's the one concern.
Yeah, no, I understand. I think for the most part, for the bead mole for the purpose of transient elastography is for us to really just locate the liver and make sure that we're actually on the liver and not on, say, another adjacent organ or the rib, but not really for assessment for, HCC or liver tumor. But certainly, I think having that feature, at least it'll help us ascertain that we're in the right location for the fibrosis scanning. Could you write down the codes for insurance coverage? Yeah, so it's 91200 and 76981.
So the code actually right now reimbursement from the FibroScan was in between $30 to $40, and for the higher code right now is about 100-ish. However, if we do this code, then the next question is that if you send patient for the ultrasound, like myself, I do the ultrasound, and number one, you cannot do the ultrasound and any of the modality at the same day. You are not going to get denied. Number two, as you just mentioned, we wanted to say it's in the liver. However, if you fail for this in the future, are they going to find out, say, wow, you only do only small part of the liver, you're charging on the ultrasound part. So that's the concern.
Yeah, that we'll have to see. But on the report, I think we're specifically indicating that this is for the purpose of just echolocation, but not for the purpose of HCC screening. But of course, I think for that purpose, we would have to do as either a separate ultrasound on a separate day or other imaging modality. But just for the purpose of transient elastography, the BMO imaging is just purely for locating the liver for better scanning experience. Let's see.
I think I'm trying to understand like Sharon J. Cox's question. She said, say more about lean fatty liver as a problem. I think one of the main things is like underdiagnosis. I think if you don't think of it as a cause, you'll never look for it. And also the problem is when you're trying to get like therapies, and then you see, it's so difficult to sometimes convince that like the lean NASH is a real problem, right? Because they're like the reviewers who are on an insurance side have these cutoffs of BMI, cutoffs of whatever they have cutoffs for, and they're like, oh, but they don't meet this cutoff. And then it's like such a huge hassle to explain this whole lean NASH to somebody who they say is like peer reviewer, but then it's not even like a gastroenterologist or a hepatologist. Like you're trying to teach a whole concept of lean NASH on a 10-minute phone call. So that's like a challenge in its own, and then this is why I think the people end up you see a lot of even for Indians for that matter, Indian origin people, you see a lot of early cirrhosis with lean NASH, and then they present with decompensated cirrhosis because nobody's watching these people because they think they're not obese, so they don't have any issues.
Mm-hmm. Yeah, that's the major problem, lean fatty liver. So that's actually is a challenge for all of us. And as we know, it's a silent disease. Even in the early liver cirrhosis, you don't have any symptom sign. Your liver enzyme can be totally normal until the point you find out the platelet count, thrombocytopenia, etc. But at that point, a little bit too late. So, how can we make this more aware and the insurance company understand that? As you mentioned, talking to the insurance company, that it's talking to the internal medicine. They are the medical director. They don't know what is MASH, the lean fatty liver. They don't.
Mm-hmm.
That's pain in the neck to talking to them, to educate them what is lean fatty liver, lean especially if the liver enzyme is normal.
Mm-hmm. Mm-hmm. Okay, all right. Well, thank you both so much for this session. I think we've had some very good insights from the both of you. Great perspective on this epidemic. So I want to thank you, Dr. Devuni. Thank you, Dr. Wu, for this exciting talk tonight. So tonight's discussion highlighted, that while MASLD is a rapidly growing challenge with non-invasive tools and multidisciplinary collaboration, we can detect these diseases earlier and improve outcomes. So, and lastly, on behalf of High Sky Medical and Next Gen Therapeutics, thank you all again for joining us tonight. And we appreciate your time and engagement, and we look forward to continuing this important dialogue. So have a wonderful night, everybody. Thank you.
Yeah, thank you,
Thank
everybody.
you.
Thank you, Dr.
Thank you.
Dr.
Have a
Devuni.
good night. Thanks for
Bye-bye.
joining. Bye.
Bye-bye.